Well, thank you very much. Thank you, Professor Lerch, for the introduction, and I would like to express my thanks to Professor Poor that I could be here at the 5th meeting. And I already was there at the first meeting when Professor Alkalwowski in Cluj invited me, and I think we have intensified already during the breaks our collaboration possibilities, and I'm very happy to see that, and I think that will certainly give us for the future more options. So thank you very much. Now, alcoholic liver disease, I start with a slide. Bacchus has drowned more people than Neptune. How many more? A lot more. Almost 500,000 people die in Europe every year due to alcoholic liver cirrhosis. This is 50% of all liver death. This is almost 1% of all death, and 1 out of 10 alcoholics die due to the liver. This is enormous data. Now, who drinks? Everybody drinks. The adolescents drink, the female drink, the men drink, and the elderly drink. So everybody drinks. It's a problem which is really for everybody clear. Now, one problem we have, the scientific interest in liver disease at most important liver conferences was shown here. It's very, very low. You can see that alcoholic liver disease is very low with respect to HCV and HBV. Now, of course, since HCV has now solved the problem, it will be more apparent with alcoholic liver disease. And I hope the future would bring us more like these meetings where alcoholic liver disease is addressed. Now, the natural course of the liver disease is rather clear. When alcohol hits the liver, almost everybody gets a fatty liver. But only a subset of people, a third about, gets alcoholic steatohepatitis as shown histologically. And only 1 or 2 out of 10 develop alcoholic cirrhosis. So 8 out of 10 do not. And the question is why? And then there is that special thing of alcoholic hepatitis, which I address a little bit later. Now, why is that so? Because there are modifying factors. The amount of alcohol is relevant, and genetics, I come to that a little bit later. We have seen more data in the recent years. Gender, female gender is very prone to alcohol. Other liver diseases, drugs and toxins, vitamin A and alcohol is a very bad combination. And smoking. If you smoke more than 20 cigarettes, you have a 3-fold increase for alcoholic liver disease when you drink. Genetics. This is relatively new, the last 5-6 years. And we have 3 genes which are important in alcoholic liver disease, which are also important in non-alcoholic fatty liver disease. This is the PNPLA3, as you all know, and this gene codes for a hydrolase activity. It is involved in fatty acid metabolism. A second gene, TM6SF2, is also involved. It obviously has an effect on the secretion of very low density lipoproteins, and the variant causes intrahepatic fat accumulation. And the third gene, MBO87, has something to do with a substrate we have extensively addressed this morning with phosphatidyl acetylation, with a lecithin. So all 3 genes work on fat. So I think they are relevant with respect to fatty liver, and this is also the case with NASH. And they certainly modulate the course of the disease. Now, what about gender? This is the old Becker study from Scandinavia. You see the females on the blue line and the men in the red line. So females develop at a lower alcohol intake already alcoholic liver disease and alcoholic cirrhosis. Don't ask me why. There are a lot of hypotheses. Metabolism of alcohol in the stomach due to ADH, body water is lower, increased levels of alcohol, but estrogens may possibly be very important factors. Now we have learned that obesity is a risk factor, and we do not drink only, we also eat. So I think it's a little bit artificial if we only look at somebody who drinks heavily and who eats heavily. Most of the people, they do both. They drink and do both. And this is a picture, a photograph, which I have taken in 2005 when I was at the European Liver Alcohol meeting in the south of England. And I come across that slide in the night. And you see, it was very clear to me that between Nash and Ash, these are 2 villages here, is only Sandwich. So I think that was a very interesting observation. Indeed, the food may play a role between alcohol and non-alcoholic fatty liver disease. And this has been shown in a French study. You see the normal people with the body mass index 21, and these are the obese ones.
and they have taken alcohol quite a lot, almost 120 grams. But those who are obese, they have the 100% increase in their cirrhotic livers. And of course, if you look at the significance, then you see age, female, we discussed that, body mass index, the obese is more on risk, alcohol, glucose as a sign for diabetes, and Pearl's grade as a sign for iron in the liver, and Professor Müller will touch that topic a little bit later. Now, very interesting is if factors associated with HCC development in NASH, and one factor is alcohol. This is a retrospective study, the ASHA study, but still there are other studies from Japan in the meantime. And what you can see is if you drink alcohol, even at a social level, not only heavily, you have an increased risk for hepatocellular cancer in the future. So the question comes up, and this is a very important question because it was raised all the time, is it good if somebody who has non-alcoholic fatty liver disease to drink? Because alcohol, we know, improves the peripheral insulin resistance. And what came out was one study by the American group Shalasanasi, and also a study by us, which came to the conclusion that until further data from rigorous prospective studies become available, people with NAFLD should avoid alcohol of any type or amount. In other words, people who have NASH should not drink. People who have a fatty liver, this is another issue. They may have a little alcohol, but NASH people should not drink. Now, what else makes the difference? Underlying diseases, hepatitis B we know, and hepatitis C is well known. If they drink alcohol, they have an increased fibrosis occurrence and more cancer. Hereditary hemochromatosis makes sense because of the iron in the liver. And more recently, from Dr. Trautuein's study in Aachen, heterozygotes of alpha-1 antitrypsin deficiency, they also have an increased risk. What about diagnostics? Diagnostics is very clear. Gamma GT is very alcohol specific. If you have only gamma GT, it doesn't say anything about toxicity. It doesn't say anything about the function of the liver. It says alcohol. If it's 1,000, 2,000, or 3,000, my patient with the highest level had 4,200 units per liter gamma GT. The liver was just fat. And if you have that high level, it's alcohol. If you have lower levels, about around 100, there are differential diagnoses, like non-alcoholic fatty liver disease, diabetes, medication, drugs, hypothyroidism, and so on. There is a list of that. Then, of course, you have occasionally increase in triglycerides, in cholesterol, and you have a low platelets, not only when the spleen is big, also alcohol by itself decreases platelets. And don't forget the uric acid. People have not only taken livers to eat and other things from organs. Uric acid is sometimes a good sign for too much alcohol. In the inflammation state, transaminases increase, and GOT, AST, is always higher than GPT, ALT. Mostly twofold or more than twofold. If this is not the case and you know that he's an alcoholic, you have to look for an underlying disease such as hepatitis B or C. And if you have a non-drinker who has a higher GOT than GPT, a NAFLD person, then he has a bad prognosis. That's what we know. Of course, there are alcohol markers, but I do not go into detail about the markers now. We know that with markers, you have a better possibility sometimes to identify an alcoholic. What about the fat? We talked about fatty liver. This is a recent study from our Danish friends guided by Professor Müller and published, and you see that indeed with a cup, with a controlled attenuation parameter, you can easily detect the increase in fat. This is the hepatic steatosis score, and this is the increase in fat. And when they stop drinking, the fat goes back, the fat regrets, but only in the normal size, normal weight people. If you are obese, the regression of the fat in the liver is only slow or sometimes not given. Now, FibroScan, we have heard much about FibroScan. I think our group were one of the first showing that FibroScan indeed in alcoholic liver disease shows a very clear, significant diagnostic tool. And you have cutoff values of 12.5 for cirrhosis and 8, and there is a gray zone in between. And this has been compared with many others, with a fibrometer test, with other serological parameters. But FibroScan elastography is still the best. However, one has to consider a few factors which influence that. Not only fibrosis, but also inflammation. We have heard that. Cholestasis, of course, and venous pressure or arterial pressure increase liver stiffness. Professor Müller has published on that issue on the perisinusoidal pressure theory. Now, what can we do if we have a low a low pressure, then there is no chronic liver disease. If you have an increased pressure, then look at ultrasound and lab test and intervene, detox alcohol, drain your biliary tree, and take diuretics to take off the congestion from the right heart, and then you do it again. And then you come to the real liver stiffness measurement. If this is not possible, hyaluronic acid is still possibly the best serological marker for that. Now, a new study also from our group, also under the guidance from Professor Müller, caspase-cleaved keratin 8 fragments increase during alcohol withdrawal and predict liver-related death in patients with alcohol liver disease. These are fragments which show apoptosis, and I think that's very interesting when you have high levels of M65 or M30, then indeed your mortality is different. I think that's an important issue, and one can use that also for prognostic purposes. Now, what about alcohol hepatitis? This is a special thing. Alcohol hepatitis is a clinical syndrome which is characterized by jaundice, anorexia, and loss of liver function. Histologically, a typical feature can be seen, including inflammation, necrosis, and fibrosis. Mortality depends on the severity of the disease, determined through scores. I come to that in a minute, but it is generally high. And you see that this develops from alcoholic steatohepatitis, which is the histological type, but it also can be in alcoholic cirrhosis, 40%. This is an acute on chronic disease, a very severe specific disease. This is the histology. You see the fat in the liver, you see the infiltration of polynuclear cells, and you also see the perivenal occurrence. It starts perivenally, not periportally. And you see here, this is very typical, and also you see the Mallory-Denk bodies, which is not unique for this issue, but it is important because it also gives you some kind of prognostic issue. There is an alcoholic hepatitis histological score from the Barcelona group, which shows that if you have a lot of infiltration of polynuclears, is a good sign. It's better than if you don't want. There is more reparation possibly. And if you have oval cells, regenerative cells, this is probably a bad sign. So it's very interesting to look at that scores. Now, what about the prognosis? We have all learned the MADRS score, which consists of bilirubin and prothrombin time, is very good. A MADRS score above 32 gives you a 50% mortality within 1 month. There are other scores, the MELD score, the Glasgow hepatitis score, very important one, which takes into calculation kidney function. All the others take into calculation kidney function. That's an important point. The Lille score, I come to that in a moment, and also the Barcelona APIC score. They are all good, and you can use whatever you want to use, but take in calculation that the Glasgow score is beside the MADRS score a very important score. What about therapy? Abstinence is the cornerstone of therapy. Regardless what type of alcohol liver disease you have, if you stop drinking, it will be better at the fatty liver stage, at an inflammatory stage, at the cirrhotic stage. Even cirrhosis, early cirrhosis can be rebuilt. So abstinence is very important. Very difficult to achieve, I agree. We can discuss that, but very important. Now we have nutrition, steroids, and we don't have pentoxifylline anymore. The STOPPA study showed us. I always said pentoxifylline is a drug and medication on the search of its indication. So I think it was, obviously, no side effect, but it was not very convincing. And we have liver transplantation. What about nutrition? There is improved malnutrition and complication if you give 2,000 calories per day to these patients. Mortality, questionable influence, but you give 2,000 calories per day. And if you look at enteral diet through the nasogastric tube, effective, but poor compliance and insufficient data for parenteral diet. Now, no proven advantage for parenteral nutrition, branched-chain amino acid, as we have learned some 30 years. Some of you may remember the story of branched-chain amino acid. That's out. Anabolic steroids, it's out also. Vitamin substitution, except of one vitamin. Keep that in mind, thiamine, vitamin B1. If you don't give it, you have a big chance to go into Korsakoff-Wernicke syndrome. So they need vitamin B1. Now steroids, and I said update 2018, and you see this is an old study, 2002. There is not much new, but it was a good study from Philippe Matteron. Data on 3 randomized controlled trials. You see the numbers. You see all sick, all very sick with a MADRS index over 32 without infections, without bleeding. And you see 85 to 65 different significant. I'm not sure if that's so very convincing, but it's good, it's significant. But only 1 out of 5 had an advantage. And age and creatinine have also to be considered. So the Glasgow score, whenever you have a score about 32 and you need a Glasgow score with 9 or more, then you treat. I always want to see the Glasgow score because the Glasgow score takes the creatinine, the kidney function, into consideration. Now, the steroid response, and this comes in the Lille score. You see, if you give steroids, then you have to give that for 7 days and you have to see if there is an early change of bilirubin level. If bilirubin goes down at any level, then you have a responder. And you see the difference here between the responder and the non-responder. If you have a non-responder, you can continue with that. It will not help. It will create problems with infections or sepsis. This is the problem here. So let me summarize the steroid therapy. Steroids should be given in alcohol hepatitis with DF more than 32 and GASH more than 9, Glasgow index more than 9. Prerequisite, no bleeding, no infection. Treat the infections before. Look for urinary infections, respiratory infections, and infection in ascites. Problem, septic complications. And keep in mind the early change in bilirubin levels. Now, some studies have been continued in 2011. NAC was given, N-acetyl cysteine was given in addition to prednisolone, and the short-term survival was improved. Not the long-term survival, there was no difference, but I think it's important to keep them short alive so that we can see what we do with them a little bit later with these patients. Now let me summarize, what do you do, the algorithm so far. If you have recent alcohol abuse, jaundice, loss of liver function, then exclude other causes of liver injury, drugs or sepsis. Then you look for the prognosis scores, MELD, MADRE, GASH, ABIC, Lille, whatever you want. If you have a low risk, then it's fine. You look at the nutrition status, you give them nutrition, as you see here, and go into supportive care. If you have a high risk, then you treat them, of course. You give nutritional support, you give prednisolone and an acetylcysteine, and you think about to stop it when you have a non-responder. If you have a responder, you continue. If you have a non-responder, well, what can you do? And then it comes to the study, of course, which was published by the French and Belgian group on liver transplantation without 6-month rule, without keeping these people 6 months without alcohol. And you see, if you treat them by liver transplantation, and this was only the case if everybody agreed. The people on the ward, the hepatologist, the anesthesiologist, the psychiatrist, the surgeon, if they all agree, then they transplanted that person. This is a person, a classical person, 35-year-old woman, first time in hospital, jaundice, never detoxificated, and she is a non-responder. So they did that, and they found the very interesting results were very clear. Data, and the Americans have copied that now, and they found the same result. So the question is, 6 months rule is out, more or less, but we have problems with organs in Germany, so this is a problem of public discussion. Now, let me come to the end, simplified pathogenesis of ALD and various therapeutic options. Gut bacteria, we have heard, are important. They go to endotoxins, Kupffer cells will activate it, chemokines and cytokines, osteopontin, TNF-alpha. There is apoptosis and there is oxidative stress. There is a lot of targets which you can hit. And of course, this has been tried with antibodies, with antibiotics for the bacteria, with endotoxin clearance by detoxification, calends or antibodies. There were steroids, of course, pentoxifylline, TNF-alpha antibodies, apoptosis inhibitors, CYP21 inhibitors, antioxidants, and also antibodies or anti-interleukin 1 or 22. But what came out, make it brief, not much. Not much. Steroids still remain. Here we have data in animals, and we have CYP21. And this brings me to the final data which have been published a couple of weeks ago. We looked, since we are dealing with CYP21 since 30 years, carcinogenic ethanodine adducts in alcohol liver disease, correlation with CYP21 and fibrosis. What does that mean? That means that CYP21 correlates very intensively in 100 patients from whom we have biopsies with the ethanoadduct DNA and also with fibrosis. For the first time, this could be shown. And what's behind that? We all know alcohol induces CYP21, and this induction leads to reactive oxygen species. They lead to lipid peroxidation products, and they bind to DNA, leading to ethanoadducts. And these ethanoadducts, they may have genetic or epigenetic effects and may lead to fibrosis or fibrosis comes directly from ROS. So this is very important, and we have started a trial in patients, which has been finished a week ago, where we gave patients a CYP2E1 inhibitor to inhibit CYP2E1, to inhibit ROS, and see what the liver is doing. The study is finished. I will not show the data today. I will show it at one of the next meetings. We have not completely analyzed, but as Professor Müller would say, they are promising, these data. So we'll see what finally comes out. Now let me summarize. Alcohol liver disease is the most frequent liver disease in Europe, and I know from papers and from personal conversations with persons in Romania that's also here very, very high. The sequence includes pure alcoholic fatty liver, steatohepatitis, cirrhosis, and hepatocellular cancer. Alcoholic hepatitis is a clinical syndrome, jaundice and inflammation with high mortality. Only 10 to 20% of heavy drinkers develop cirrhosis. Negative factors, among others, are genetics, female gender, obesity, and underlying liver disease of other etiology. Pathogenesis includes translocation of endotoxins from the gut with secretion of cytokines, oxidative stress, and the action of acetaldehyde. I had no time to go into that in detail. The patient's history, laboratory profile, and clinical appearance lead to the diagnosis. Hepatic fat is determined by CAP, fibrosis by FibroScan, and inflammation activity by histology. Alcohol abstinence is the treatment of choice in all stages. We can discuss that. And therapy of cirrhosis does not differ from therapy of cirrhosis of other etiology, including liver transplantations. I talked a bit about the 6-month rule. Alcohol hepatitis is treated according to prognosis scores with prednisolone and hyperalimentation and NAC, and liver transplantation has to be discussed. It's still a matter of debate, and that's our group. And I would thank you for your attention. Yes, thank you very much.